Well, guess what time it is? It's 4 o'clock in the mountains, which means 6 o'clock on the East Coast and 3 o'clock on the West Coast, and it is time for Fertility with Fink and Friends. I am Fink, and you are friends. And welcome everyone live from CNY Fertility in Colorado Springs, where I am the clinical director of IVF services and also the medical director of the Miami Center of Excellence and CNY Fertility at the Miami Center of Excellence. It's great to have everybody with us today. Looks like, people are joining from all over the place. Well, you know what? I have to go up to the first person who joined here. So we've got Instagram on a couple of different Instagram feeds, the CNY side, my side. We've got LinkedIn, we've got Facebook, and everybody is here today. And it looks like Annie Blooms is the first one who joined on the Instagram side. Thanks for being here. And I see. Oh, look, Allie is here. Hi, Allie, on my side. Thanks for being with me. Looks like Nancy is here from Miami. Nancy, it's good to see you. And Brandis is joining us from San Diego on vacation. Maeli was the first one to join here, and great to see everybody here. I hope you're having a wonderful day and a great week. How's your week been? What's been up in your world? So here it's 89 degrees in Colorado Springs, 89 degrees, which means, it's a warm one, but you know what? It's warm and dry. We're in the high desert here, so it's easy to come and get dehydrated. But it's not as hot as it is in a lot of places. All our friends in Texas and across the Southeast are really suffering with some high heat. Hi to Sheila from Tampa, and it looks like a first question over here. It comes from the Facebook side, and this is Haley. Are back-to-back retrievals worth it? I'm 40 years old and I only want one more baby, and I have four 3-day embryos, 4-day 3 frozen embryos. Trying to decide if I should do another retrieval to improve my chances or just transfer some embryos. Well, so this is a good question, and the question is always, when do I do more retrievals versus just getting some transfers done? So the question that I ask in that situation is, how many babies would you like to have? And the answer that I get 100% of the time is, we would be happy if we just had one baby. And I know that is the fact. And I know that's going to be the answer. We would be happy if we just had one baby. Okay, at this point, by the time you've been through everything that you've been through, you would be happy if you had one baby. But what does your heart tell you? What does your heart telling you that you really want? What did you always want? What have you fancied? Was it always, well, I really wanted to have 2 babies? Well, so think about it this way. If you did a transfer and you got pregnant, then realistically, it's probably going to be, another year and a half before you could do another retrieval. In a year and a half, in most people, certainly if you're over the age of 35, that amount of time is pretty significant when it comes to potentially affecting egg quality. So if that's the case, then maybe you do want to do your retrieval now. If you can honestly say, well, I would be happy with one baby, and I'd say, and you've got, 2 or 3 embryos, then maybe it makes sense to just go ahead and do a transfer. You can transfer both those embryos together depending on your age, and will tell us what the guidelines are. So in your case there, Haley, you could transfer 2 or 3 of your embryos and have them all together. If the transfer doesn't work and you're not pregnant, then you're really talking about 1 to 2 months delay before you, in theory, could do another retrieval cycle. So if that were the case, it might make sense to go ahead and do your embryo transfer now. But if you're thinking, gosh, we were really hoping to have, 4 kids, I'd say in that situation, you want to be able to bank your embryos. You want to get as many embryos as you can, as soon as you can, because the earlier we get those eggs from you, the greater the probability that we're going to have good egg quality. And that's kind of really what we're after. It's all about the egg? We're getting so many good questions here, and I'm going to try to get to everybody. Hi to Ruzik Blue from Las Vegas, as always. Nice to see you. Um, I just got off the phone with a very nice patient, and let me click on something here so I can just see what we were doing over there. I just got off the phone with a nice patient who was kind of faced with a very similar choice. What was going to be the best thing to do? Um, and it also, there were questions about when should I do a retrieval? Should I do transfers? Should I do retrievals? And she had also had endometriosis and had endometriosis surgery back in October, and is debating on, well, does it make sense to do a to do suppressive medication for endometriosis when the surgery was, about, let's call it 9 months ago. There seems to be some empiric evidence that if you have surgery for endometriosis, and of course, endometriosis is that process where that lining that normally sloughs off when we have a period, instead of coming out the door, instead works its way up north here and implants inside the pelvis and around the pelvic organs, and can have a negative effect on both implantation and on egg quality overall, as well as egg reserve. There seems to be some evidence that having an optimum surgery to remove as much endometriosis as is present. Now, with endometriosis, we used to just kind of try to kind of burn it. We used to kind of cauterize it and to try to take care of what we could see by just destroying it. But what we've learned is that endometriosis is what you can see is really just the tip of the iceberg. There's always going to be more than what meets the eye. So it may make more sense, instead of just trying to cauterize it, to actually remove it. So excision of endometriosis, or kind of cutting that portion of the tissue out, is really the best thing to do for endometriosis now. And if the surgeon feels like they have been able to optimally remove the endometriosis, and we'll call that debulking the endometriosis. If they've been able to remove all the endometriosis that they can, then that may buy you about a year, hopefully, of time when the endometriosis is gone, is suppressed, and you really don't have to do anything about it. That seems to be the case. It's kind of an empiric thing. I don't know that there's any published data on that, so that's hard to say. But much beyond that, then it starts to make more sense to think about doing suppressive medication for endometriosis before doing a transfer. That medication is not something that is going to delay you for a year. It is not something that's going to delay you for 6 months. It's 60 days of medication, and that shows us that if we had an optimally suited embryo, let's say a euploid or a chromosomally normal embryo, and we placed that embryo inside of you, that should give you about a 60% probability of being able to get pregnant. But if the endometriosis is present and it is being expressed in the lining of the uterus, and there's a protein that we can look for in that, and it's called BCL6. If the BCL6 protein is positive, it'll take that 60% number and decrease it down to really about 12 or so percent, which is not very good, especially with a euploid embryo that should have our highest probability of pregnancy. So that's the rationale. If we treat that for 60 days, it can bring us back up to that 60% number. And so interesting scenario, and endometriosis is such a common thing. And one of the observations that I've made about endometriosis before is that, there are times that we might, there are some people who have endometriosis who have a pain syndrome. It's chronic pelvic pain. It can sometimes even be really quite debilitating. But there are also, but then when we go do laparoscopy to look inside and see what's there, see if we can treat something, they may only have one or two small spots of endometriosis. It may, what you feel may not correlate at all with what we find inside. Other times we may go do a laparoscopy for other reasons. Let's say someone's going to have a tubal ligation. They're going to have permanent sterilization. And we go in to look at the fallopian tubes and we see that they are covered with endometriosis, but they have absolutely zero symptoms. So it's a peculiar bird, that endometriosis, but it is certainly more common than we might think. And so that's one of the reasons that we suggest that you test for endometriosis, particularly if you've had recurrent implantation failure. So if you keep putting back embryos and you're not getting pregnant when you should be, endometriosis may be one of the things that we consider. So hopefully that's a little helpful information there. Oh, actually, and Haley, you know what? I forgot to answer your question there about back-to-back retrievals. Back-to-back is a good thing. So what a back-to-back retrieval is where you do your stimulation, you do your retrieval, and then, about 10 days or so later, you get your period, and then you start on your next stim. When you do that, we typically, those are also called stacked cycles, we typically start to get improved outcomes each time. And that is to say that that the medication, let's say, that you use during June is going to continue to help you in your July retrieval. So our numbers often go up, and certainly the egg quality goes up. So a back-to-back is in general, yes, a very good option. All right, Haley is here. Let's say, we got another Haley. Well, that was one Haley, and here's another. This is my friend Haley, who we did a transfer here, and Haley had a transfer last week and got a positive test yesterday. You couldn't hold off from testing early, could you? You just couldn't do it. You couldn't wait. But look at there. Well, fingers crossed, my friend, that everything continues going on in the right direction, and we're all right here with you. What a great piece of news that is. We've got Sheila, who would like to know, what would you recommend for someone with thin lining? 2 DNCs, and ever since then, the lining hasn't gotten beyond about 6 millimeters. So for an embryo transfer, we're generally looking for your lining to be about 7 millimeters if we can. Some people, it just can't get there. And if it's at 6, then we can actually look with the ultrasound and look at the blood flow that's going to the endometrium and may see that it looks plenty adequate. But would we like it to be thicker? Yeah, we would. So what can we do in that scenario? Well, intrauterine PRP is a very good option. And we've talked about PRP before. PRP is where we take a tube of your blood, comes from your arm here, and we can separate out the components that become your body's healing factors, your tissue factors, your growth factors, and we can place that back inside of you. We can place it inside the ovaries. This can sometimes help with egg quality and potentially ovarian reserve. It's used in cosmetics and aesthetic medicine. It's used to treat, I know I've said this before because I remember talking about my own hairline here, that it's used to treat hair loss. It can be used for lots of things. But when we put intrauterine PRP is where we take a teaspoon of this fluid that comes from your body and we place it inside the uterus. It is packed full of the most important and the most delicious growth factors your body can use. It's probably the most soothing salve you can get, and that will often do the trick for a thin endometrium. Now, if oral estrogen and vaginal estrogen don't work, did you know that there is an injectable estrogen as well? Sometimes we can use transdermal, so that's a patch. The patches typically aren't absorbed as well. And so, to be honest with you, even in the hormone optimization world, when you come to me with menopausal symptoms and we are trying to fix you to make you feel better, to feel more like yourself, to give you back a sex drive, to give you back soft and beautiful skin and hair and all those things for hormone optimization, um, um, it's popular to use estrogen patches. But remember, the job of the skin is to keep things out of you. The skin is an organ, and its goal is to prevent things from getting in and affecting your inside organs and the rest of your body. So that's why we have to take good care of it, especially when we're at the beach. You heard me. Oh, you heard me. Um, we tend to shy away from the estrogen patches. But there is an injectable estrogen. It's called estrogen. It's very inexpensive and it's very effective, particularly for people who have a difficult time getting that lining to be thick. So there are some options for you. So let's see what we got going on here. Oh, I just saw a handle I like. Awkward. It's Awkward Mara. Hi, Awkward Mara. I like that. I thought it said Awkward Mama, and I thought, no, that is a good one. I like it. Okay, unapologetically, Ened, is that what that says? Thank you. That's funny. Ms. to Mrs. Bugs. Hi from Georgia. Glad to have you here. And Life with Imberlane from South Carolina. We've got David from California. Gosh, everybody is here today. And I'm looking for some questions on this side. How long after a D&C, this comes from Creative Love 86, how long after a D&C to remove scar tissue should you wait to do IVF? Okay, so sometimes inside the uterine cavity, we can get some scarring. The scarring happens generally because of the mechanical things that we're doing to that lining of the uterus, and it can cause really the top layer of the uterus to kind of become stuck to the bottom layer of the uterus. And this is what we know of as scar tissue. This is really most common after a D&C, oftentimes after a D&C for a miscarriage. But anything that can cause that we have to go inside the uterus for can cause scarring. The other common place that we will see that is in the event of delivery, after delivering a baby, having a retained placenta, where we have to go back to the operating room to help the placenta come out. These can leave some scar tissue inside the uterus. When that uterus becomes really scarred, it has a name. It's called Asherman's syndrome. And that's something that we generally can treat using the camera that goes inside the uterine cavity called a hysteroscope. Hystero means uterus. Scope is to look inside. So a hysteroscopy or a hysteroscopy is the camera that goes inside the uterus to look and kind of see the lining and see what's there. In the fertility world, we are often doing this to try to remove polyps and growths that may be taking up valuable real estate that's trying to prevent an embryo from being able to implant. So that's what we're looking for. But it sounds like in your case, Creative Love, that you had some scar tissue. They did a procedure to go inside and to treat that scar tissue. Sometimes that scar tissue can be dense. It can be thick, and sometimes it's filmy and thin. So when we cut that scar tissue or to treat it in order to break it apart, you say, how long to wait to do IVF? Well, if you're talking about doing an embryo transfer, typically it's 1 to 2 months. It kind of depends on how thick and how detailed or how aggressive that surgery had to be to break apart that scar tissue. If you're talking about IVF from the point of an egg retrieval, you can do that immediately because, and in fact, there are a lot of folks who come to us and say, well, I have to have a surgery because I need to take care of a fibroid or I have some fluid that's in my fallopian tube, or something that I'm going to need to do here. And so I'm thinking that maybe I want to do that surgery first before I do my IVF, just because I want to get it over with. And my answer to you would be, please don't do that. Please get your IVF done as soon as you can, because the earlier we get the eggs from you, the better off we're going to be. The younger you are when those eggs come out, the better off, the better the egg quality will be. And so if you go to have a surgery on something that's then going to delay your IVF for 3 to 6 months, that is enough time to make a difference in terms of the quality of the eggs that can come from you. So typically 1 to 2 months after scar tissue, although that may depend on how much had to be done inside of you. But if it's about an egg retrieval, do it immediately. In fact, I would have done the egg retrieval before I went in to try to fix the inside of the uterus. Jordan Marie is here and says, I have been on the wait list since April. And the appointment is until the end of August. I call all the time for waitlist updates. Tell you what, Jordan, drop me an Instagram message, and that's Randy Fink MD, and let me see what I can do, because gosh, that's a long time to have to wait. I understand that the wait list is often it may take about 3 months to kind of get over the fence and in to get an appointment here. And on the one hand, I'm glad that we are able to take such good care of people, and that enough people want to come see us, and that we're trying to help so many people. But I know that that's getting to be a little bit long. April till August is a little longer than I think you should have to wait. So maybe let me see what I can do to help there. On the Facebook side, Bailey Salazar is saying, what is the BMI cutoff for Colorado? Well, good question. Technically speaking, we don't have a BMI cutoff. However, our anesthesia folks start to get nervous when people's BMI is greater than 50. Now, we do have folks that are greater than 50 all the time, but just depends on if there are any other illnesses, other kinds of things that are involved. The operating room in Syracuse may be better suited if your BMI is over 50, but this is an individualized decision, and something that we can certainly help to walk you through, Bailey. So by all means, reach out to us and let's talk about your situation personally. Valerie is asking, she says, Dr. Frank, good to see you again. Well, first of all, who is this Frank? Huh? And why is he on my Instagram? This is Fink and Friends, not Frank and Friends. Gosh, I swear. Okay, Valerie, I'm going to let you by with that one, okay? Dr. Frank, good to see you again. You did my egg retrieval in May and ended up with 2 3-day embryos. Looking to come back for another egg retrieval at the end of the year. That's outstanding. Okay, well, I guess I'll stop abusing you about calling me by the wrong name. But look, can you see? It says Fink. I am 40. Do you think I should stay on the same meds for stimming next time? Well, so that's another, it's a good question there, Valerie, because I think the answer falls in, well, okay, so you did a stim in May and you're thinking about coming back, maybe 9 months later. And that is enough time for things to change in your body, especially at the age of 40. So the first thing I would want you to do is to be on the list of supplements that are for egg quality. And if you've been on these lives before, you know that it comes from the book. It starts with the egg. If you Instagram me, Randy Fink MD, I will send you that list of medications. You can click one button to get them from Fullscript, and that makes a big difference in egg quality. But what I would look at is to say, well, okay, how did you do with the first stim? How did we do with the number of eggs retrieve, the number of follicles, the number of eggs retrieved, the number of mature eggs, the number of eggs that degenerated, what kind of result did we really get there? And I would make a decision based on that. I would not suggest that you automatically go in using the same protocol. So I think that's definitely worth a consultation Valerie. And if you want it with Dr. Frank, I mean, I know him personally, so I'll see what I can do to try and get you there. Okay. Can middle schmerz, this comes from Shilva, can middle schmerz get in the way of getting pregnant? So middle schmerz, you know what middle schmerz is? I have always liked the name just because it sounds so, it's dramatic. Middle schmerz is painful ovulation. So some people, when their ovary releases the egg, have some not insignificant pain, and in most cases, sometimes it's just for a few minutes. Sometimes it can last for an entire day, or sometimes even two. Can that stand in the way of getting pregnant? Well, so at least it's telling you that you're at the right time. It's the time of your ovulation. It's when your beautiful little ovary is releasing its egg. So it may help you some with the timing. Middle schmerz is usually caused by a chemical cascade that's called prostaglandin. And actually, prostaglandin is in very high concentration in semen. And so if you've ever heard that sexual intercourse is a way of ripening the cervix around the time that you're going to have the baby that may help to get you into labor, it's because prostaglandin is used to ripen the cervix and make it more ready for labor. So semen contains a high level of prostaglandin, and certainly it's a necessary requirement for getting pregnant. So I don't think that middle schmerz itself is associated with a difficulty or standing in the way of getting pregnant, but certainly if you're in pain around the time of ovulation, it means that, well, you may not be as interested in having sexual relations. And that's probably also an important consideration when it comes to getting pregnant. So I suppose it depends on how long it lasts, but middle schmerz in general is a physiologic concern. It's something that happens in almost all women at some point, so shouldn't be too big of an issue in most people. All right, let's see what else we have here. Bree Bales. Hello, can you give me more info? Oh, actually, you know what? I just put in, Bree is a patient of ours, and I hope you don't mind me talking about this here, Bree, because you asked the question here, so I guess that means it's all right to talk about. Bree has had 3 positive biopsies for chronic endometritis. So endometrium is the lining of the uterus, and endometritis is an infection or an inflammatory process that's happening inside the uterine cavity. We can tell this by doing a biopsy, and that biopsy is with a little straw that goes inside, sucks a little piece of tissue out, that goes to the microscope doctors, who can look at that and tell us what they see. The presence of an immune cell that's called a plasma cell. Plasma cells are the immune system's marker for chronic inflammation. There are some people who have a chronic inflammatory process in the lining of the uterus that's very hard to get to go away, that it's very hard to eradicate. And sometimes we will treat this, and we will treat this, and we'll treat it again, Bree, and it's still there. That can be frustrating. And in your situation, I recommended maybe you want to consider doing the Emma and the Alice test. Emma and Alice are a test that go hand in hand with something that's called the ERA. I am not recommending an ERA very routine, certainly not routinely, but very rarely anyway anymore. It's not considered to be a very useful test. It doesn't affect the pregnancy rates. People get pregnant whether irrespective of the timing of that test now in most people. But the Emma and the Alice are a test that allows us to be able to identify specific organisms, specific types of bacteria that can be inside the uterine cavity. And that environment is supposed to be sterile. There's not supposed to be bacteria up on the inside there. And so the M&EALIS test, it's done during a particular time during the cycle, and it's either in a medicated cycle. It can be done in a natural cycle as well, when we're not trying to do anything about the timing of receptivity. And again, just a little endometrial biopsy. And they run a special test in the laboratory to be able to identify what specifically are the bacteria that are on the inside that can be contributing to this. And so in your situation, I thought that's probably a good idea. We do have a very broad spectrum antibiotic, medication protocol for chronic endometritis. I'm not sure that that's the best thing if we can identify specifically what the problem is. And so that's why I thought that might be a good idea for you. But yeah, sometimes it is hard to get that endometritis to clear. The typical medication that we use for chronic endometritis is 14 days of doxycycline. Doxycycline is a very safe medication. Many people have used it to treat acne on the face before, but it covers most of the pathogens, many of the pathogens in the vagina and the cervix and the uterus as well. So that's what I thought for you there, my friend. Tiffany is asking, Tiffany Sunkiss Cutie, I like that too. God, everybody's got such good names today, especially that Dr. Frank guy. Tiffany, does BMI play a major role in failed transfers? The evidence says that there is a lower fertility rate or a lower, ongoing pregnancy rate for women who have a higher BMI, but the evidence does not say that if you were to lose a bunch of weight and alter your BMI by 15 points, it may make your periods more regular, it may make you healthier, but it does not necessarily improve the ongoing pregnancy rate. So does it play a role? It plays some kind of role, but I think things are becoming, we're just kind of becoming more and more aware of the multifactorial nature of how weight can affect pregnancy. Certainly, once you are pregnant, there's a higher risk for certain pregnancy complications and things that can happen. So it stands to reason that if you want to be at as healthy a weight as possible when you get pregnant, just because you're going to gain weight with pregnancy, and that weight gets a lot harder to lose once you have the baby. But specifically, does it play a major role in failed transfers? I would have to say, if you'd asked me maybe 3 weeks ago, I would have said, I think it probably does. But I just read some evidence that says that actual BMI probably does not contribute so much to failed embryo transfers. Now, are there some other factors involved that might? Yes, that could be. But BMI itself, really, probably not. IVF for Ali Walsh, we have 2 low-level mosaics that were retested and are now euploid. Is that common? Yes, it is. So a mosaic embryo is one that has because we've got 2 sets of chromosomes, right? I'm a 46XY. XY is the male chromosome. We got 46 or 2 pairs of 23 chromosomes. So basically, a mosaic is when one of those cell lines is not normal, but the other one is. So what percentage of it is abnormal determines whether it's a low level or a high level mosaic. And in many cases, when these are retested, they do, in fact, come back as normal. Now, I would not recommend that anyone do retesting on a mosaic embryo, because the data also shows us that a mosaic embryo has every bit the probability of being a normal baby as does your euploid embryo. It's just that it has a slightly lower chance of implanting. So a euploid embryo has about a 60% chance of implanting. An untested blastocyst has about a 30% chance of implanting. and a mosaic has probably about a 40% chance. So it has a little higher risk for miscarriage, but if the pregnancy continues, it is every bit as likely to be normal as the euploid embryo. So I wouldn't put an embryo at risk to thaw and rebiopsy, or even to get the lab to try to run that biopsy tissue again, because in all probability it is a normal embryo. But good deal, Allie Walsh. Looks like Lindsay Smoot says, I have PCOS and an AMH level of 19. That's a respectable number. Didn't respond well at all last IVF round. Only one egg after 23 days of stim. Now that's very interesting. So is it useful to prime with birth control next round, or would that be too suppressive for already resistant ovaries? I probably would not prime with birth control. Birth control can help with the timing of IVF to batch cycles. It can help to bring to make follicles more consistent in their synchronous is the term we use, in their size. But most people with an AMH of 19 with polycystic ovaries are going to be very, very sensitive to medication. They're going to respond very, very well and very aggressively. But there is a cohort of that group who is going to be very resistant to responding and just need higher doses of medication. And it is usually that simple, my friend. It's just simply using a higher dose of medication in order to get the response. We wouldn't know that because 95 or more percent of people with an AMH of 19 are at very high risk for ovarian hyperstimulation syndrome because they're going to be so sensitive to the medications. So I wouldn't say right off the bat, oh, well, here's someone with PCOS, so we're going to have to use these very high doses of meds. No, we go the opposite extreme. We want to use lower doses because less is more. We're looking for quality over quantity. But it's your situation, Lindsay, when we see that, oh gosh, it actually, you're resistant. It wasn't working the way it was supposed to, and we need higher doses. So that's how I would focus on that one. Let's see, we got a bunch more questions over here from the Facebook side. If you just joined us, it's about 38 minutes after the hour. I'm Dr. Randy Fink from CNY Fertility in Colorado Springs. Happy to have you at Fertility with Fink and Friends. I am Fink. You are friends. And let's see what we have here. Ann Landis is asking about the difference between medicated versus natural frozen embryo transfers. So the difference between a medicated cycle is what they have been using in IVF since IVF was invented, right? So there's 40 plus years of experience with it. And so that's a good thing. And that's basically 6 to 12 days of estrogen, followed by an ultrasound to show that that estrogen thickened up your lining, followed by 6.5 days of progesterone injections, followed by the embryo transfer, and then you need to get progesterone shots, progesterone in oil, typically to about 10 weeks of pregnancy. That's a medicated cycle. A natural cycle is where we let your body's own hormones contribute. And in a natural cycle, just like if you were going to have a normal period of your own, you develop a follicle, and that follicle makes estrogen, and the estrogen causes the lining to grow by itself, so you don't need to be putting in the extra estrogen. And then we can see, when we see that the follicle is of a mature size, we can trigger your ovulation, which starts the clock ticking on when you're going to have your transfer. But sometimes people will want to ovulate on their own, and that's okay too. When your ovary is going to release the egg, and when that happens, it becomes a little progesterone factory. So we supplement you with just some vaginal progesterone. You don't have to do the progesterone injections. A little bit of vaginal progesterone, and that's what's called a natural cycle. If possible, personally speaking, I prefer a natural cycle. Why? Because I've got my own opinions here, but the facts say that a natural cycle may be a little more successful. It has a little higher pregnancy rate. It has a little lower miscarriage rate. And it has a lower rate of certain types of pregnancy complications, specifically blood pressure complications coming down the road once you are pregnant. The fact of the matter, really, I think, is that, even if your body is not working the way it's supposed to, even if you've been trying to get pregnant for a number of years, it may mean that something's not working right, but it doesn't mean that everything isn't working right. You're built to get pregnant. We as humans are built to procreate. So if we can use our own skill set or our own hormones or what our bodies are trying to do in order to get there, it seems like that's just a better idea. Now, there are some circumstances where a medicated cycle is the best choice. So it's not perfect for everyone every time, but it's certainly something that I would consider. And if you're thinking about it, do ask whether whether a natural cycle is appropriate for you. And now there's also something that's called a modified natural, and I'm not a fan of the modified natural, and I would recommend against it unless you need to. Modified natural is where we use ovulation induction. So let's say that you have polycystic ovarian syndrome and you never release an egg on your own. Well, you can't do a fully natural cycle because you don't release your own egg. We have to get you to release that egg. And if we have to do that, then I think it starts to ask the question, is it really worthwhile to do it? I don't know the answer to that, but if you release the egg on your own using letrozole to quote unquote make sure that you release the egg, I think can be more harmful than helpful, in my opinion. And even though there are a lot of folks who will immediately grab for the letrozole to say, oh no, you should do a modified natural because that's better. We're going to make sure that you ovulate. I don't believe it is. If you ovulate on your own, let your body ovulate. Make your own hormones, and let's see if we can get you pregnant that way. So hopefully that's helpful there. What else we got here? Maya, when can we start our transfer? After hysteroscopy and removal of a polyp. Next cycle. So, we try to do these hysteroscopies in the first half of your cycle so that we can make sure that you're not pregnant. But then by the time you get your next period, that lining has reset and you are otherwise really good to go. Kimberly Norris is here. Hi, Kimberly. In our last retrieval, we only yielded 3 embryos. So we did a day 3 freeze-all. Can we transfer more than one day 3 embryo? The answer to that is yes, you can. There are always individualized recommendations, based on people's individual stories, but transferring more than one day 3 embryo is oftentimes or sometimes can be within guidelines. So I would say in your situation, Kimberly, that's probably a good plan. Oh, look, Bama Gal is here with us on my Instagram side, and that is my mother. Hello, Mama. Let's see. Kirsten said did an HCG and PRP wash, which was excruciatingly painful. Interesting. Can I do a Valium or something for pain and the wash again next FET? Well, I will tell you, I'm sorry to hear that it was terribly painful. It can be crampy, but really it shouldn't be painful. Valium is not a very good pain medication. We use Valium sometimes at the time of embryo transfer because it has been shown to be a muscle relaxant and can prevent over the course of the day the uterus from spasming. What I might do beforehand there, Kirsten, is probably 800 milligrams of ibuprofen. I'd say if you're going to do this in the morning, take that ibuprofen with your breakfast. If we're doing it in the afternoon, take that ibuprofen with your lunch. It should last you for about 8 hours. The effect, certainly at least 6 hours. And that probably has a better effect on anti-cramping, the kind of cramping and discomfort that would be associated with more severe pain. And gosh, I sure am sorry to hear that that was such an experience there. Should you test for toxoplasmosis before FET? Not recommended routinely. Um, can someone, and this comes from Erica, someone with regular periods and ovulation, but a short luteal phase, do a modified natural transfer? And the answer to that is yes. Because remember, with that natural transfer, it's not that we're just sort of throwing you out into the wind and saying, well, we're just going to let nature take its course. No, we're still monitoring everything. And if there's something that isn't right, hormonally or mechanically or sonographically, we're going to address it. We're going to treat that. So, Erica, yes, even if you have some variations in your cycle, you absolutely can still do that. Can still do a natural. It looks like a Wrath 10. If you have a blocked tube due to scarring, do you typically recommend removal before transfer? So if that fallopian tube is blocked, it means it's not going to work for you for sperm to be able to swim through it. But if it is not full of fluid, there's no reason to remove it. If it is full of fluid, and that's what's called a hydrosalpinx, hydro is fluid, salpinx means the tube, then yes, you want to remove that before doing transfer, but simply a blocked tube does not need to be removed. We've got Michelle over here on the CNY face or Instagram side. Would you do IVF for a 46-year-old with no health issues and decent ovarian reserve? How many rounds of IVF should we do? Well, I will tell you, Michelle, that the odds of being able to successfully conceive at 46 with IVF are unfortunately dramatically low. And it's not just because of ovarian reserve. So I see some 45 and 46-year-olds who have great numbers in their AMH. Their ovarian reserve is high and looks great. The problem is that as we mature, the stability of the eggs, the stability of the DNA within our eggs becomes well, I should say the eggs become less stable, that DNA. And that makes it harder to produce an egg. That makes it harder to fertilize an egg, and certainly makes it much less likely that the embryo is going to be able to grow, because the embryo is more likely to be chromosomally abnormal. And so that's why even in nature, a 46-year-old is certainly less likely to get pregnant spontaneously. So we at CNY will not turn you away if you're 46 and would like to try, because many people feel that they, that if it's going to happen, it may happen to them. And you know what? It can happen sometimes. So I would certainly say it's worth a try if you'd like, with the understanding that most places would tell you that a donor egg is going to give you a very high probability of pregnancy. But certainly I understand that that may not be the reason that you're doing this. You would like to give it a shot with your own egg. And if that means trying, then absolutely it's worth trying. Again, realistic expectations. Where does gestational carrier surrogacy cost less than $100,000? That's a good question. I don't deal with that myself. I certainly deal with gestational carriers, but not involved in the finance. Our donor team may be able to help you with that. So feel free to reach out to the donor team at CNY. And let's see what else we have here. Does a laparoscopy for endometriosis help with both retrieval and transfer? This comes from Candy 822. Hi, Candy. Or is it just for transfer? And if that's the case, do you do it before retrieval? Does it hurt your chances? So, in the olden days, a laparoscopy was a mandatory part of everyone's evaluation for fertility. And it's not so much anymore. Endometriosis can be a cause of diminished ovarian reserve and issues with egg quality. More commonly, we've been able to overcome those things with modern medications, and it becomes an issue of affecting the endometrium for transfer. So I personally consider it more important for embryo transfer, even though there are also some non-invasive ways to arrive at that same diagnosis without surgery. Doing it before retrieval should not hurt your chances. Although, when we do surgery in the ovaries, for instance, let's say that you have a collection of endometriosis fluid, and that's known as an endometrioma, then that can affect your AMH or your ovarian reserve. So in general, we kind of advise to keep out of the ovaries if at all possible when fertility is on the table here. Over on the Facebook side, looks like Maya, I think it's Maya, maybe it's Mia, but we'll go with Maya. Is day 11 too early to ovulate in a cycle? The answer is no, not necessarily. Because the issue is the lining of the uterus going to be thick enough that if you ovulated and a sperm came along and fertilized it, and that embryo floated its way down to implant inside the uterus, is there going to be enough lining there at that time to make a nice, spongy, warm, juicy place for the egg to implant? By day 11, the answer is probably so. And that's the way your cycles normally are. And that's an easy enough question to answer with ultrasound. So day 11 is probably okay, but I'd certainly want to know what the lining looks like. This comes from Toyin, who says, which is better between fresh or frozen embryo transfer? Well, so a fresh transfer is included in the price at CNY. So if you can do a fresh transfer, by all means, do it, but you can't always do it because sometimes your body will tell us, no, not such a good idea. Remember, during a stimulation, your body is in egg-making mode. And if it's in egg-making mode, it may reach the point where it just isn't going to be in getting pregnant mode. So that's the situation where the hormone levels might tell us, probably not the best idea. In almost all cases, the success rates with a frozen embryo transfer are a little higher because of that reason. Now, people do get pregnant with fresh transfers literally every single day in the CNY system, but there are some clinics who don't even do fresh transfers because the success rate with frozen may be so much higher. Let's see what else we got here. Thoughts on taking Provera to induce a period to start IVF. Well, you can do that. So Provera is progesterone, and it is often our go-to to cause people to have what we call a withdrawal bleed, and that will cause the lining of the uterus to slough off. But what that's suggesting to me, and this comes from Mini Mita, that the situation there is that you're not ovulating. So normal circumstances, your ovary releases an egg, and the egg hangs out and waits to get pregnant. And if sperm comes along and fertilizes the egg, then you're pregnant. And if not, the brain says, okay, we're not pregnant, shut off the hormones, clean everything out, and we're going to start again fresh next month, which is the signal to have that nice normal period. If you don't release the egg, you don't get the signal. And so your body's not sure what it's supposed to do. And so you may go for months without having a period, or then you may just kind of start to slough off lining, and it just keeps sloughing and sloughing. And 21 days later, you're still bleeding. That's called an anovulatory bleed. But so in your case, Mini Mita, it may be that your ovaries are really just quiet, that they're not doing anything now that you don't have a follicle there, and that hormonally your body still thinks you're at the beginning of the cycle because you haven't developed the egg. So you may not need to induce that period to start the IVF. You may just be able to start it, which is why we usually tell folks that if 28 days, we always tell you, we want you to contact us on day one of your cycle, right? Radio in, or rather a portal message in on day one of your cycle. But if 28 days goes by, 30 days goes by, and you haven't had your period, tell us anyway. By day 48, I would say you're probably not ovulating. So I would just go ahead and do a baseline and see if you can't start at that point. Can I do a frozen embryo transfer directly after a retrieval? So the answer is yes, you can do so you can do your fresh transfer, and then we just thaw that frozen euploid embryo like you have. You have frozen euploid embryos. We just thaw it, and you can place it back in typically on day 5 after your retrieval. Absolutely. And hi from Burlington, Vermont to Kimma Wilson. We've got just a few minutes left here on Fertility with Fink and Friends. Let's see if we can get a few more answers. Age 43, trying for my first since 2000. Okay, that's a long time. You've had 2 losses. Do we try medicated cycle first or jump to IVF? Well, I think your highest chances of pregnancy are going to be with IVF, ma'am. So IVF is the most reliable and the fastest path to pregnancy. And doing medicated cycles in our 40s typically doesn't give us success rates that are significantly higher than home intercourse alone. So I would think IVF is going to be your better bet there. Oh, there's my friend and away goes Paige. Is embryo PGTA testing typically complete within the cycle after a retrieval so that the transfer is possible the month after retrieval? Generally speaking, yes. What you can do is to do your retrieval, and then you have to do really a medicated cycle is what you'd want to do in that next cycle, because we can kind of keep you on some estrogen just to hold things at bay until the PGT results come back. So figure it takes day 5, day 6, or day 7 to get to the blastocyst stage where the embryo can be biopsied. And then it's about 10 to 14 days usually to get that result back. Now, sometimes it takes a little longer, but that's a good question to ask when you're here to get your retrieval, because we'll have a sense of how long things are taking to get back. How big does the follicle need to be before egg retrieval? So we usually trigger you when the majority of your follicles are greater than 50% of them are above anywhere from 17 to 18 millimeters. That's kind of what we're looking for. Let's see what else we have. I think we got time for another question or two. I got my blood results back today. Low DHEA, even though I'm taking 50 milligrams of DHEA per day. And this comes from Joyce Haddad. Joyce, the correct dose of DHEA that's evidence-based, specifically for folks with lower ovarian reserve, is 25 milligrams 3 times a day. And that's what I would recommend that you be on. Can endometritis cause miscarriage? That's a hard question to answer. I think more likely a miscarriage can cause endometritis, and endometritis can affect a future implantation. But does it cause a miscarriage itself? That one I think is probably not as clear. Eileen is here. Hi, Eileen. Well, gosh, now it looks like we're going to be out of time. So, gosh, sure, I'm happy everybody was able to join me here today. As always, every Tuesday at 4 o'clock in the Mountain Time, it's Fertility with Fink and Friends, live from CNY Fertility in Colorado Springs. As I am fond of saying, infertility is not your book. It is not the title of your novel. It is not your picture on the cover of the magazine. It is only a chapter. And what we're here to do together is to rewrite that chapter. God bless you all. Thanks so much for being here this Tuesday. I have a wonderful, wonderful, happy week, and we'll see you next week. Till then, good night.